Namaskar, friends. Good evening. I'm Deeptisharma Joshi on behalf of California TV MEDI Talk Show from Global Healthcare. I would like to introduce Dr. Kavita Tyagi, who is an eminent cardiologist. She's an interventional cardiologist from Sir Gangaram Hospital, Delhi, India. And today, ma'am is there in the studio. I would like to welcome Dr. Kavita Tyagi in the studio. Namaskar, ma'am. Dr. Kavita Tyagi. She is an interventional cardiologist from Sir Gangaram Hospital. Ma'am, I just want to understand what is interventional cardiology.
Yeah. So thank you so much for inviting me on this platform. And can I see my slides? Yeah. So today we will be discussing about advances in cardiac interventions. So somebody will do it. Yeah. So about cardiac interventions, it is said that anything a cardiac surgeon can do, an interventional cardiologist can do as well or better percutaneously. Next, please. So coronary angioplasty started in 1977, the first human coronary balloon angioplasty performed intraoperatively. And in 1977, Andreas Group performed first cath lab PCI on awake patients. Starting with this case, all PCI data entered into a registry. Next, please. So we have evolved, all of us, and so is the angioplasty, and so is the cardiac interventions. Next, please. Now, we have come to a stage wherein we are talking about differences in cardiac interventions, differences in cardiac presentations of the diseases in men and women. Next, please. So, evolution of interventional cardiology. Concept of percutaneous intervention as an alternative to surgery evolved after the coronary interventions, and now it has been a revolution, it has been a paradigm shift. Percutaneous repair of the mitral regurgitation, transcatheter aortic valve replacement, left atrial appendage closure, and leadless pacemaker, and so on and so forth, for which previously only surgery was the option available to us. Next, please. And we are here to witness the revolution. Next, please. So what is in the box? We can have many further interventions like OCT and IVUS and FFR in angioplasty. We have the mitral valve interventions, maybe balloon mitral valvotomy, mitral clip, or percutaneous mitral valve replacement. We have the aortic valve interventions in the form of TAVI or TAVR. We have LA appendage occlusion, and we have percutaneous pulmonary valve implantation. We have leadless pacemaker implantations. We have subcutaneous ICDs. We have left ventricular assisted devices, and we have home monitoring of pacemakers, and so on and so forth. Next, please. So normally people have lots of doubt about, when somebody undergoes a coronary angiography, they feel that doctor will do angioplasty. Sometimes they feel that doctor might not have done it indicated. But people should be aware of that. Now we have further parameters with us, further technology available to us. When we ourselves are in doubt whether this particular stenosis should be opened up with a stent or not, we have further interventions with us available to us. Example, FFR, which gives you idea in a borderline lesions whether this coronary stenosis is significant, it should be opened or not. So we do fraction flow reserve test, that is FFR. And when we want to see the coronary arteries from inside, like what kind of plaque it is, was it simply a rupture, was it a plaque, was it a thrombus, was it a calcification, and from where to where the stent should be placed. For these we have OCT and IVUS. OCT, that is optical coherence tomography, and IVUS, that is intravascular ultrasound. So these are the recent advances, not precisely recent, they are advances now very well available to all of us, and we are utilizing them day in and day out for optimizing our decision for regarding angioplasty and optimization of the stent placement in coronary arteries. Next, please. So here, this is how angiography looks like. Next, please. And this is how, as you've seen in the previous slide, The RC lesion it looked like a borderline. So we can always do FFR for RC lesion. And by these quantifications, we can make out. Next, please. Just keep on clicking it. So this is RC lesion, and by doing FFR, by putting a wire across this lesion and by connecting it to our system, we can measure that the gradient across the stenotic lesion was significant, and then we decide that this artery should be opened up. Then we decide that it should be opened up. It should be opened up with the balloon followed by angioplasty with the stent. So we open such kind of lesions. So in borderline lesions, this FFR is a very good intervention which we are utilizing nowadays. Next, please. So next, if we see, this was done FFR to LAD lesion, and FFR to LAD lesion was not, this also came to be significant. So we could decide that LAD as well as RCA should be opened up. Next, please. Now, next comes this OCT. OCT is optical coherence tomography. When we see acute coronary syndromes, acute ST elevation MI, especially in young patients, we are not sure of whether we put a stent, we should put a stent or not. So what we do is we take OCT catheter and we see lesions from inside. Was it a simply plaque erosion or was it a plaque rupture, and how unstable the plaque is and how big the plaque is. So all these things, this OCT run helps us to decide whether we should do angioplasty or not. So in this case, we did OCT and it showed borderline luminal area. So post dilatation also we can decide with the help of OCT. Next, please. Next, please. And this FFR is again used to see if residual stenosis is significant or not and how much post dilatation is required or not, especially in the side branch lesions. So FFR for grading the stenotic lesions and OCT for understanding the type of plaque and for understanding from where to where we should be putting stent across the artery. These technologies are useful for us day in and day out. Next, please. Now coming to mitral valve interventions. Mitral valve interventions, we do two things. In rheumatic heart disease patients, when valve is narrowed, if it doesn't have significant mitral regurgitation, then we open it with the help of a balloon and we call as mitral balloon valvotomy. And this is BMV, it has been done since quite long. And in rheumatic heart disease patients, especially the countries like us, this BMV technique is very useful for the patients. In fact, in many patients, we repeat it 2 or 3 times also before the patient goes for actual mitral valve replacement. Next, please. And this is also done percutaneously.
Dr. Kavita, I just want to ask you, what are the emergencies in cardiac interventions?
Yeah. So cardiac interventions, emergency is acute ST elevation myocardial infarction. That is, people commonly call it as a major heart attack. When patient comes to us with a chest pain or breathlessness and ECG shows ST elevation MI. So these are emergencies. We take patient immediately to the cath lab and we do angiography and we find one of the 3 arteries 100% occluded. Then we open it immediately with the help of wire, balloon, and we put a stent. We require to do thrombossuction. And sometimes these patients are in cardiogenic shock, or sometimes these patients are in deranged heart rhythm. So we put a temporary pacemaker implant also. And if patient is in cardiogenic shock, then we put a IBP support also. Similarly, patient who comes in complete heart block with the cardiogenic shock, this is also a cardiac emergency. These patients are rescued with the help of a temporary pacemaker implantation initially, and we take the patient out of cath lab, and then in 1 or 2 days we plan permanent pacemaker for such patients. Then third cardiac emergency is pericardial effusion, which makes blood pressure very low and patient's condition become very critical. So such patients are dealt with pericardiocentesis, that is, we remove the pericardial fluid from outside the heart. Other emergencies are like patient comes in cardiogenic shock or patient comes with very dangerous arrhythmias. Those patients are dealt with either DC cardiogenic shock, or we deal them with multiple medications.
My another question goes, what are the elective interventional procedures, ma'am?
So elective intervention procedures remain. Patient comes with chest pain. which is classified as either chronic coronary syndrome, uh, stable angina, or unstable angina. And this type of anginal pain comes and goes, and patient's ECG does not show the ST elevation kind of changes. If troponin comes positive, or if patient has arrhythmias, or if patient's blood pressure is falling, or patient is facing arrhythmias or heart rate abnormalities, then these become sort of elective, but little urgently we deal them by doing angiography and by opening the artery whichever is causing the problem. Or if patient is having stable angina, but patient is getting certain amount of angina on certain amount of task, then these patients are sort of elective, and we call them, we admit them, and then we do their angiography. Similarly, the TAVI procedure is also a elective procedure, wherein we do aortic iotogram, TAVI protocol. We assess patients' femoral arteries, peripheral circulation. We assess aorta size. We see calcification. We measure aortic size, and we decide aortic valve. This one, and tower is done within after preparation of 1 or 2 days. So tower is most of the times it is elective procedure. Similarly, BMV is also elective procedure. We assess patient's mitral valve properly through 2D echo ourselves. We assess patient's clinical condition, and then we do this procedure. Similarly, EPS RFA is also elective procedure. So, if you want to understand elective versus emergency, then emergency remains ongoing heart attack, ongoing arrhythmias which are causing blood pressure to fall down, or which are causing cardiogenic shock, or pericardial effusion which is causing blood pressure to come down. So these are the immediate procedures to be done, and rest are the other elective procedures.
Ma'am, what are the advances in cardiac interventions?
So advances, as I told you, advances are depending on field to field. Like in coronary arteries interventions, advances we are doing now FFR, IVS, OCT. Other than that, now for the calcified arteries, we have a lot of calcium handling materials with us, like IVL, intravascular lithotripsy. The balloon is costly, but it deals with the calcium very safely and very effectively. So IVL is advanced, and now laser treatment for dealing with the calcium has also come in vogue, but not available everywhere. So these are the coronary intervention advances. And left ventricular support devices, we have the IABP since long, but now we have the Impella, we have the LVAD. But problem with them is that for country like us, they are costly devices actually, because all of us, we are not health policy secured people. Balloon, as far as valve is concerned, we have TAVI, we have mitral valve interventions, we have tricuspid annular interventions also. As far as the left atrial appendage occlusion is concerned, we have left atrial occluse, because when patients are in atrial fibrillation, so they're prone for left atrial thrombus, which goes to brain, or which can cause stroke, and which can cause clot anywhere. So left atrial occlusion devices are the advances, which not every center is doing, but people are doing. But the only problem is that these newer advances are costly for a country. As far as arrhythmias is concerned, radiofrequency ablation, we have many advances like left bundle branch pacing, then his bundle pacing, then three wire pacings like CRTD and CRTP. I will not say it is advanced, because it is since quite a number of years we are using it. And if you see other interventions in arrhythmia, then we have cool therapies, the with the help of gases, different gases. We do radiofrequency ablation with low temperature systems. So these are the advances available to us.
Ma'am, my next question is, what are the public myths associated with cardiac interventions?
Well, yes, first and foremost myth is, I think people think that whatever a cardiologist is doing is to earn the money and not to give patient any benefit. So in this, I mean, this is, I think,
Ma'am,
most frank thing that
many
we do.
times doctors are saying, many quacks or the doctors who are not from the cardiac background, they are saying that these doctors who are performing cardiac operation, they are cardiac stentologists. How can you comment on this statement?
Yeah. So people should understand that if there's ongoing heart attack, and if your doctor is calling you and showing you the angiography, and he's showing you that one artery is 100% occluded, kindly allow your cardiologist to put a stent in there. because that is what only going to save the myocardium, the heart muscles. Don't call your cardiologist, stentologist at that moment, especially because in that case, you and your patient is only and only losing the myocardium. Doctor is earning or not, that is a separate issue, but patient is definitely losing the myocardium. See, as far as the stable cardiac symptoms are concerned, when you undergo angiography, you have time. Kindly take angiography, kindly take other opinions, kindly try to understand how much the patient is symptomatic and what you want your doctor to do. So that decision is always in your hands because you only have to sign for angioplasty. Without your sign, your doctor will not do angioplasty. So that public has to understand this is public's right. So rather than calling your doctor stentologist, and I mean, you should understand that your right was to take your patient for angiography, and you must understand that after angiography, doctor has to call you, doctor has to show you what is the findings in angiography, and doctor has to explain you that this particular artery is requiring a stent, and then you have to sign it. So that time you can always say, no, doctor, I don't want to sign it. I don't want to get this procedure done right now. I want second opinion, third opinion, fourth opinion, or whatever. So in case when your patient is not undergoing a heart attack, acute heart attack, when your patient is not undergoing acute chest pain, so you have time to decide. So don't call your cardiologist, stentologist. You take your own time and you decide, and then you inform your doctor that this procedure we want to undergo, or we don't want our patient to undergo.
Thank you, doctor, for giving us such a valuable information. My other question goes because previously there is a myth associated that the patients who are in geriatric age group or the patients who are above 40 years, they will get heart attacks. But these days we are seeing a patient of 20 years and more than 25 years are also getting an heart attacks, MI, without any cardiac history. And these days this data is increasing. This percentage of patients who are getting a sudden MI is increasing day by day. Please give a brief glimpse on this.
See, so patients have to realize that strong family history contributes to early onset of coronary artery disease, the bad lifestyle, your dyslipidemia, and many of the young people we see nowadays that they are having hypertension, they are having dyslipidemia, they are diabetic also, their cholesterol is bad, they're smoking, they are going to gyms, they are taking steroids, they are taking branched chain amino acids, they are eating a lot of junk food. So they don't accept their own deranged metabolic profile. That is number one. And they are smoking, they are doing a lot of smoking. So when they land up with a heart attack, they feel that possibly it was doctor's mistake that he or she diagnosed the heart attack in a patient of chest pain. So, but we as a public have to realize that there are genetic causes of getting heart attack. Plus, there are some of us we are prone for heart attacks at early age, and most of us our lifestyle is very bad. So we have to blame our lifestyle also. And if there is a heart blockages which is causing you heart attack, then it should be opened up, and the doctor is doing for you in time, that you must appreciate. For that, doctor is not responsible. Your own lifestyle, your own genetics, and your ignorance and your willingness to not accept the disease is responsible for that.
Yes, ma'am, you have given a very valid points about the early patients who are developing this cardiac histories and MIs. Ma'am, I just want to understand that as a cardiologist, what is the advice you want to give to the population, Indian population, that how they can take care of their heart well so that they will not become a patient in future years?
See, as far as our country is concerned, we all are so prone for heart diseases that we should be taking care of our heart health right from our 20 years of age and onwards. Because nowadays these lifestyle diseases are starting at an early age, and our children are eating junk food and they're smoking and they are doing all other wrong things also at a very early age. So from 20 years onwards at least, or whenever they meet doctor first time, they should make sure that they check their blood pressure, they check their lipids, they check their sugar, and then they check their other parameters. And if they have a family history of sudden cardiac death, then they should get their echocardiography done to detect any HOCM or something. And before going into any strenuous physical activity, they should undergo a ECG test and echo test done definitely, so that any the channelopathies which are caused for sudden ventricular tachycardia or ventricular fibrillation, sudden cardiac death, it can be caught up with a hint. So proper lifestyle modification, proper investigations, because we all Indians get these cardiac diseases 10 years earlier than other countries, and our diseases are more severe. We are getting more calcified arteries, and we require earlier bypass also, because so many stents cannot be put in so many arteries. And people have to know that uh, still heart attack is most common cause of sudden cardiac death beyond the age of 35 years. So any symptom is not to be ignored. Any symptom which you are getting and you did not get relieved with your routine medications, suppose gas symptoms, people ignore it so much. But if your gas symptoms are not reducing by your taking your gas medications, kindly consult a doctor, kindly take your ECG, kindly get your other tests done. Plus, you can always do these tests easily, like CT coronary angiography, you can always do, which has negative predictive value of 99%. If your coronaries are normal, then test will be normal, and you can be comfortable with your uh, other things.
Ma'am, these days you are doing lot of campaigns in mass community for awareness of cardiac problems, their prevention, detection, and also in eradications. You have adopted few police stations in Delhi, and you are running these campaigns of CPR trainings in different universities, schools, colleges, also in different officials, whether they are corporate institutes and some hospitals also. You are training them with a CPR trainings, and more than 200 CPR training you have already given in different parts of Delhi and NCR region. Ma'am, please give a brief description how you are able to manage these type of campaigns, these type of free medical health checkups that you are running, and uh, uh, and what is the result of conducting these type of camps in the community, ma'am?
Results, it is difficult to say that how much it must be impacting the community, because I feel you keep on doing and it must be having some impact on somebody. Once a month, we conduct such camps, and we are able to manage because we want to do it. That's the simple answer. And wherever we get a chance, we at least measure people's blood pressure, take their sugar, take their cholesterol levels, and ECG. So baseline things, at least we find that in areas wherever we do the camp, 70-80% people come whose blood pressure or whose sugar has been checked first time in their life. So we can at least tell them that, see, your blood pressure was high, you are not knowing, your sugar is also high, so kindly get investigated yourself further. Or your symptoms could be cardiac symptoms, kindly go to a cardiologist, get your proper investigations done. So I think it must be having some impact on the society, though we don't have any, because we don't have any system of that sort in our country. Everything cannot be informed, everything cannot be taken into data. I also don't have that much time, but I think I just want to contribute to the society in whatever way I can.
Ma'am, you are being invited by many federations as a medical fraternity to counsel and guide and train their medical doctors. Like you are running the regular campaigns for the DNB students, for the PGs, and also for the interns to upgrade their knowledge. How you think is the importance for training and giving them these type of refresher programs?
Obviously, they are doctors in making, so they are to be given maximum possible training. So internship is the period wherein people undergo internship in various departments. So then they develop interest in which particular field they have to go. So that 1 year of internship period is very important. After that, people do MD and MS. In that time, they decide which field they want to undergo super specialization. So in them also, if they get a cardiology exposure, so certainly they develop more interest in the cardiology. And then people who are doing cardiology, then they need to be trained for hardcore cardiology further, for interventions and for clinical as well as rehabilitative cardiology.
Yes, Dr. Kavita, I just want to understand that there is a medical tourism, the importance of medical tourism in the domestic and the international market, because a lot of patients are there who are from the different states. They are from the rural backgrounds who are coming, getting themselves treated under your guidance and observation, and after that they go back to their villages, and their villages are very far off and remote. So how you are able to manage these type of patients who are coming from the far flung places and taking a medical advice from you? And I also want to understand from you that you have got lot of international patients also from Africa and many other countries like Gulf countries and neighboring Nepal, Bangladesh, Sri Lanka, and adjoining states like Sikkim, Arunachal also. So how you are able to manage and synchronize with them? Will you are you giving them the tele information, or are you asking them to come and guiding their doctors for further treatments? Or because it's very difficult for them to come again and again, they get themselves operated under your guidance and then they go back, and it is very difficult for them for follow up. So how you can manage the follow up with them?
So it is actually difficult for them to come. But now, with the advances of our internet data available to everybody almost in our country, so people are very frequently utilizing the WhatsApp, and they do WhatsApp video consultations, they do WhatsApp audio consultations, they keep on sending the reports. And whenever we get time, we keep on referring the reports and we keep on advising them whatever we can do. But obviously, the penetration cannot be 100% like this. But yes, telemedicine is very effective and very meaningful for this purpose, and people are actually utilizing it.
At the time of Dr. COVID, you have helped lot of patients, more than 1,200 patients. You have helped them in getting rid of COVID by giving them screening and counseling the nurses who are staying at their home, and you have been awarded by WHO as well as Ministry of State and Ministry of Health from Indian government also for doing this work, which is really very commendable and appreciable. And you got so many awards after that in your medical fraternity also, where your Indian Institute of Medical Science also have promoted you, and other bodies also have felicitated you. So, what you are thinking about that after receiving so many awards, applauds, appreciations? How confidence? What is your confident level like?
So for a doctor, every time a patient comes, patient is new, patient is a new set of problem, and every patient has to be dealt in a new manner and a new way. So dealing with thousands of the patients doesn't increase your confidence to overconfident level. So every patient is a you have to deal as a new patient. I mean, yes, these things motivate you to do things further, but that doesn't change your strategy to deal the patients.
Thank you, doctor, for giving us, guiding us so valuable information about the interventional cardiology aspect and what are the myths associated in the cardiology. I would like to follow a series of interview with you. In our next series of interview with you, we would like to discuss on science and spirituality, as you are a very spiritual person and a strong bhakt of Gayatri Mata. Used to do lot of Gayatri mantra, and in COVID period also science and spirituality help your patient to get a better results, and it has been proved and validated also by the data that has come. So in my next series of interview, I would like to conduct a interview on science and spirituality, where you will be giving a brief introduction about your science and how spirituality helps the science.
Okay, nice. Thank you.
Thank you, doctor.
Thank you. Thank you. Thank you.
Thank you so much.
Thank you.